on to introduce our next speaker. She is Dr. Margaret Anyate Agama. I call her my sister. I'm sure you heard her yesterday when she poked at me when she had the opportunity to speak yesterday. She's a graduate of University of Science and Technology, Kumasi, where she got her medical degree. And actually one of the first doctors who bagged a combined degree of medicine and psychology. She also worked after her education, started her work professionalism in 37 Military Hospital, Ghana, where she worked for 12 years. Thereafter, joined the international development community, worked in UNFPA, which is where I met her in her indefatigable manner, worked in UNAIDS, worked in DPKO. If we all know DPKO, we will know how difficult it is for a woman to work there. And currently working in the AU in the Department for Social Affairs. I look forward to her presentation because the one thing I've known consistently about her is that she says it as it is. She speaks truth, without fear, and at the end of it, you remain friends, but she will speak truth. So I look forward to her challenging this audience this evening. I'm glad to continue to call her my sister. Dr. Margaret, please may you make your presentation. Thank you.
Thank you very much, Chinwe, and thank you to the organizers for inviting me to say a few words on maternal, newborn, and child health. I stand on all existing protocol, and I also stand on the statements that I made yesterday. I think it forms the basis for the conversation very brief conversation that we would have around maternal, newborn, and child health. Now, what I decided to do was to reference the campaign on the accelerated reduction of maternal mortality in Africa. And why I decided to reference this campaign is because it is one of the flagship campaigns of the Africa Union Commission, which was, I think I may need help with this. Can someone help me? Okay. One of the flagship campaigns of the Africa Union Commission, which was designed before 2015, when it was realized that Africa generally and broadly was not going to meet MDG 5. And so the heads of state and government came together and agreed that there must be focused attention on maternal, newborn, and child health. Then was born this campaign, which has been in existence for the last 10 years. It's 10 years old this year. Now, what we did is do an evaluation of the campaign, which began in 2017, and we completed it in 2018. And so since I was asked to be very brief, I'm going to give a very brief background and then some of the key outcome recommendations in a few slides. We are reminded that Eastern, Southern, Western, and Central Africa still accounts for 62% of the global maternal mortality. And 1 in every 13 children still is dying before the age of 5, and 38% of the newborn deaths still occur in Africa. Now, the main objective of the campaign, as I've already spoken to, was to expand the use, availability, and use of universally accessible quality health services, including sexual and reproductive health, which are critical to addressing maternal mortality. And then the campaign actually was left to the member states to design how it would be set up in accordance with their specific needs. So far, we have 50 member states out of the 55 member states of the Commission who have actually launched the campaign to date. Going straight to the recommendations, There are policy and strategic recommendations that came out of the evaluation. And the main thing was that the campaign was put in place before the end of the MDG era. And a lot of the respondents felt that it needed to be realigned with the goals and objectives of the SDGs, particularly SDG 3, and those of Agenda 2063, Africa's transformative agenda for the next 50 years. It's also been encouraged to increase the mobilization of adequate domestic sources. But I don't like the word increased mobilization, because it presupposes that there's a pot of money somewhere and that money is not coming towards a particular issue. I think more appropriate is to say generate domestic resources for maternal, newborn, and child health. And it gives you the option then to think out of the box, to engage a broader stakeholders in order to generate those resources, which then can be used effectively and efficiently. There was also the need to have stronger partnership with the AU-recognized regional economic communities. And out of the plethora of regional communities, we have 8 that the African Union recognizes, and also to engage more the private sector, not as a financer of maternal, newborn, and child health, adolescent health also, but to engage them in the planning and in the implementation, and in also in particular the monitoring and evaluation, as well as reporting and data collection when it comes to the issue. To improve and implement an accountability mechanism, and for this reason, one of the weakest points of the campaign was the accountability. It was felt that the Commission was not holding its member states accountable for the commitments that it had made to the campaign and when they launched the campaign. So after each of the launches, that was the end of it, and there was very little follow-up. Having said that, there is a website on the campaign. There is a scorecard we've just developed. Every 2 years, we produce status reports on maternal, newborn, and child health. And there have been other various reports available which have followed member states. Alongside this, we have the Maternal, Newborn, and Child Health Task Force, which unfortunately was to meet every 2 years, but met only once till last year, when it met for the second time. And we also had the International Conference on Maternal, Newborn, and Child Health, which also was to meet every 2 years, but has met twice in 5 years. And these were accountability tools which were put in place in order to monitor the progress made in the area of maternal, newborn, and child health. But it's been felt that the accountability needs to be strengthened, and for this reason, we are developing an accountability framework. And of course, going back to data and data systems and improved reporting. Now, on the operational side, some of the key recommendations that came out was increased local manufacturing of reproductive health commodities. It's felt that the importation of these commodities should be reduced and encourage our own manufacturers, by Africans for Africans, and produce these commodities and supplies on the continent. To improve supply chains and to use innovative ways of using human resources for health. And I think the community health worker example, of Ethiopia that I referred to yesterday is one of the examples. To investment and scale up of high impact interventions that work, and there should be more evidence-based advocacy for MNCHA. Now, one of the critical things was, it was felt that there was not enough focus on adolescents when it came to their sexual and reproductive health, and that the A of adolescents, for adolescents, was missing out of MNCH and needs to be put back. And indeed, adolescents have the worst indicators across the continent. It doesn't matter which country's data that you look at, adolescents are falling through the crack. And there are some simple reasons. One is the way we collect data. We collect data up to 19 years of age, and yet still by law, an adolescent is no longer an adolescent as of 18 years of age. Also, in many countries, by law, by 16 years of age, you can join the military, you can vote, you can buy a car. There are a lot of interesting things that you can do. So they are not also counted by as adolescents. And then you have the issue of child marriage, where many of our adolescents actually are allowed to marry, and countries have to, some countries are still revising their laws as to what is the exact cutoff age for marriage. So data, when it comes to the adolescents, is mixed between those who are legally allowed to marry, to have children, to go to drive, to go to the military, and those who really are still adolescents and children and in the formative years of their life. So this is something that our countries really have to look through. And the last is increased resources for specific strategic interventions. We must be effective and efficient in the resources that we have. It's difficult enough to generate them, and when we do, we must strategically use them. I think those were the key recommendations out of the evaluation that I pulled out for this meeting. And I think if the organizers allow, I can take some questions. Thank you. I don't know. I don't know if there's a question.
All right. That was quite a brief and informative presentation. Can we see you if you have a few questions or even comments on what you've heard so far? Very brief ones. So if you have a comment or a question, you can kindly walk to the microphone in the middle there, and then we can hear you speak. I mean, when we're in school, when a teacher teaches and it's time for questions, two things. You either, if you don't understand, you don't ask questions. Or if you understand it very well, you ask questions. If you don't understand it, you ask questions. And if you understand it very well, you want to pass comments. So as we said, I don't know which is which. Okay, so do we... Okay, so do we take it that we understood everything and we are fine with the presentation? All right, then let's thank her with a round of applause. So thank you so much, Dr. Margaret Agama Anyite. It's a pleasure to see you finally back home. I understand when she completed her health economics training, she came to Ghana looking for the AfHEA office, and she couldn't find it, and she was so incensed, she was so angry that where are they? After studying all these things, where are the guys? And we thank God that finally she found the office, and we saw her today make a presentation. So may I say that from here, I'm sure you have to pick up an AfHEA form and sign up as a member. Thank you very much for your presentation. Shall we thank her so much? All right, it's time for the next plenary session, a very important one, of course, and it's been put together by the Korea Foundation for International Healthcare, KOFI, and the National Health Insurance Authority. So after this session, there'll be a cocktail dinner with the World Bank. And the session is titled Ghana's Road to UHC, Improving Enrollment onto the National Health Insurance Scheme to Achieve Universal Health Coverage. The NHIS is a very important vehicle for this purpose in Ghana, and we are privileged to have very key people as panelists on this particular plenary session. So I invite to the podium a presenter cum moderator, Mr. Francis Xavier Andoeje, who is the director in charge of research, planning, monitoring, and evaluation at the National Health Insurance Authority. Shall we receive him with a round of applause?
So thank you very much. Quickly, I would like to introduce the two presenters who will be presenting alongside myself. One will be presenting on the health insurance system in Korea, and another on the health insurance system in Ghana. For Korea, we have Professor Sunam Kwan, a health economist and a former dean of the School of Public Health, Seoul National University. He's currently the president of the Korean Health Economics Association. Ladies and gentlemen, help me to welcome Professor Sunam Kwan to the podium. Yeah, thank you, Prof. Kwan. Now, the next to join us here is Dr. Lydia Jani-Selby, a medical doctor by profession with a specialty in ENT. Dr. Selby is currently the acting chief executive officer at the National Health Insurance Authority. Ladies and gentlemen, let's welcome Dr. Lydia Jani-Selby to the podium. So now that we have two of them seated, I'll take my seat and call on them to do their presentations one after the other. Thank you.
Good evening, everybody, and thank you very much for the invitation. So first of all, in the late 50s, early 60s, and 70s, we actually had UHC in Ghana because we had free healthcare for all at all government facilities. But by the 70s, we were in trouble, and by the 80s, we had gone to cash and carry. And what we mean by cash and carry is you put money down before you are treated. This obviously wasn't the best. In the late 90s, we started toying around with some community health insurance, and by 2003, we had launched our health insurance. It was enacted by an act of parliament, and it was to secure financial risk protection against the cost of healthcare services. The act was revised in 2012 because by then UHC had come on board, and we really needed to become one single administration with all the necessary safeguards of risk pooling. Currently, 37% of our population are covered, and we regulate the private health insurance as well, which unfortunately is only about 1% of the population. So, how do we fund it? We have premiums, but they are not actuarially determined, and about 65% of our population don't pay premiums. They are exempted, which is our NHI levy. We transferred 2.5 percentage points of social security contributions. We have returns on investment and some sector budget support. But the reality is, it is tax-based. The levy constitutes 75% of the income, with the contribution from the formal sector around 20%. If we look at some of the architecture, the levy and the pension contributions go to the Ministry of Finance and then transferred to the health insurance. The premiums and other incomes come directly to us, and then we pay out in 3 different ways. We give money to the providers for the services that are delivered. We support our partner agencies within the health sector through the Ministry of Health, and our administration and general expenses also come out of the fund. And this is what we call our golden tripod: the purchaser, the provider, and the member, all supervised by the ministry, who do the policy and regulation. Now, I just want to remind us about the famous WHO UHC box, because I'm going to talk about Ghana's NHIS looking at the 3 dimensions of UHC and how we hope to achieve UHC. In March 2017, the minister set up a technical committee to review the NHIA, reform and restructure it, because we have now signed the 2030 Global Compact. So looking at the 3 areas we want to address, we're looking at population, we're looking at the benefit package, and obviously the financial aspect. And this is the chart. We rapidly increased, and then we flatlined. Now, in 2007, we had the national card, so that we were one national scheme. But in 2013, we introduced the biometric to be sure we didn't have duplications in our system. Ghanaians are extremely mobile. They move from district to district at will. And until recently, we didn't have a proper address system. So it was very difficult to know the duplications in the system until we got the biometric system. And this is currently what we have, the different categories. As at the end of December, 68% of our members are exempt from premium. So the under 18s, over 70s, pregnant women, indigents, none of them pay premium, and they constitute the bulk of our members. As you can see, under 18s constitute 47% of our registered members. And we all accept that our membership has stagnated. We have 19.7 unique biometrics in the system, which is 67% of the population. But we obviously have a challenge in the renewal process, therefore clogging up our district offices. Our recent research showed that the average time spent trying to renew membership is 11.2 hours, and that is completely unacceptable. And transport costs to renew, the average is also 4.2 CDs, getting to 5 CDs, which is about $1. If we could get rid of this, the transport costs to our members, assuming only 50% renewed, is 20 million CDs annually, and that's a lot. So we need to look at initiatives to change the narrative around our membership. So about 3 months ago, we launched our mobile renewal, where people can renew through their mobile money from the comfort of their homes. Then we have a collaboration with Kofi, looking at other innovative ways. Somebody else will talk about that, so I won't bring it up now. We hope that the national ID card will allow us to let people do new registrations, again through mobile technology, without coming to our district offices. We collaborate with the Ministry of Gender and Children and Social Protection to target certain categories of people who require registration and renewal without paying any premium, processing fee, or anything. And then we have special outreach programs. So, to talk a bit about our mobile renewals, we dial *929#. If you dial *929# on any phone, it does not have to be a smartphone. We designed it to work on what we call YAM phones in Ghana. And you can check your membership, renew, check the benefit package, check the medicines list. But obviously, the dates are not on the back of the card. Therefore, we had to come up with a new way to be authenticated at the provider side. And this allows the providers to check that you are active. But because it hits our database, we now have a live data on every member who's accessing service and where. This gives us valuable demographic data on who is accessing service where to better plan interventions with the ministry and our service providers. And importantly, we now send an SMS to the member so that the member can authenticate that they really are at the provider site. Currently, this is what is happening. Less than 1% of people are actually saying no, they were not there. I can't work out whether the bad boys are not actually sending us their false authentications and validations, or everybody has decided to behave. When we started, a lot of people felt we would marginalize those in the rural areas. Not so. The urban folk are not taking it up, and it's the rural areas. And this is West Mamprusi in the northern region. And as you can see, pockets of people just hang around teaching each other how to renew. Then we come to the next portion, which is the benefit package. We have a generous benefit package: inpatient, outpatient, medicines, diagnostics. Probably the biggest issue is we don't have an inclusion list. We have an exclusion list. So any smart provider can actually get anything within Ghana's health insurance benefit package. We haven't reviewed it since we launched the scheme 15 years ago, and it's something we're actively looking at now. We have 4,385 providers, the majority of which come from the public sector, which is Ghana Health Service. The private sector has a lot of pharmacies, laboratories, chemical shops, and not so many clinical facilities. But the health insurance is actually driving the private sector into underserved areas because there's a captive market in those areas. So we are looking with excitement to see what will happen in the next few years. And who do we purchase from? We purchase from the tertiary facilities, which in Ghana, despite being public, they are semi-autonomous from our Ghana Health Service. Then we have the Ghana Health Service, which are the public facilities. We have the Christian Health Association of Ghana, which are various Christian or faith-based private, semi-private facilities, non-profit. We have quasi-government, and they are the university hospitals and other institutions who are part of government payroll, but are not part of the Ghana Health Service. And we have the private providers. You must have a license from the Health Facilities Regulatory Agency, and then you come to us for credentials if you want to be allowed to see health insurance members. We'll give you 4 years credentials, 2 years renewal after that. And you sign a contract at the regional level and not at the head office. And how do we pay? We started off fee-for-service because it was the easiest way to get started. We introduced DRGs, and then we introduced capitation for outpatient. We had to suspend it, not because the capitation was wrong, but the timing and the way we implemented it gave us insurmountable challenges. We have stepped back to lick our wounds, and we will look again at how we can best introduce a population-based payment to be able to fund everybody, at least at the primary healthcare level. Looking at the reforms, we have to do some reforms. We've got a major actuarial study going on right now. We're building an actuarial model. It allows us to plug in all the various scenarios. In Ghana, our health insurance is quite political. And when I say political, I mean the average man in the street is very involved in health insurance. So everybody has a comment, a suggestion, an idea, and we need to be very professional about how we plug in these scenarios to let the country understand the impact of adding or removing certain benefits. But I think we all agree, or Ghana has agreed, that the NHIS package must equal the UHC package if that is what we have signed up for. So whatever we design cannot be curative only, cannot focus on tertiary care. We need to look at prevention, promotion, if we want to achieve UHC. And then looking at, we've done facility mapping, and in 2 of the regions we looked at, as can be seen clearly, about 40%, only about 40% of the providers can actually deliver a comprehensive primary health care package. So it isn't only about having the package and having the members. The access to the quality is becoming an issue, and it's something we have to address. But then everybody talks about money, and that's the third dimension. And when we look at our utilization, we rapidly increased, we have plateaued. But the claims payment is relentless. Every time we think we've plateaued by putting in a new intervention, it gets out of hand, and we keep chasing the payments. And this is our income and expenditure. In broad numbers, you can see the years where we had a financing gap. And then we rein things in, and then it goes out of control again, and we have another financing gap. But going forward, we believe we must use a mixed provider payment system. We will continue with the DRG for inpatient. Medicines are fee for service. We have to see how we get it back into a basket if we want to control medicine expenditure. We need to begin to look at population-based payment for outpatient services. I think all over the world, that is the way forward, especially if you want to add prevention and promotion, and we're working towards that. And we obviously need to have robust monitoring systems and electronic claims processing. We've set ourselves a target by the end of 2020, everybody will be submitting claims electronically. We've designed an in-house claims submission application that even CHIPS compounds are using now. So we think we can get there. So what are some of the expenditure side interventions? We're looking hard at the administrative expenditure. We all know what the medical loss ratio should be, but being a social health insurance program, it's sometimes a little difficult to rein that in. We're looking at strategic purchasing. We are sitting on a lot of health data, and we need to use that data a bit more wisely in taking decisions around how we run our health insurance system. The member feedback on attendance is interesting because some members are now beginning to ask themselves, wow, do I go to the hospital that often? All these are costs to the country. And we think it will improve the way members seek health care. And we have a very robust clinical and compliance audits, which we have improved on by our collaboration with AfHEA, one of the organizations in South Korea that has a strong history of medical audits. On the income side interventions, Ghana passed a law giving us earmarked funds for our health insurance fund. And I've put it in bold and capital letters. It must be sacred. it should not be touched by anybody. And it is something that we're all working towards to make sure that the monies Ghanaians have put aside for healthcare is used for healthcare. But we are also looking at the tax exemptions. If you have a tax exemption for whatever reason, we should leave the health insurance out of it, and everybody pays that tax. We are doing e-receipting to make sure that all our revenue-generating offices, money doesn't move around in individuals' hands. The temptation can be overwhelming. And obviously, our mobile renewal, we hope, will improve enrollment, especially those who do not need to seek health care. We are extremely adversely selected as a health insurance scheme, and we realize that the mobile renewal, somehow, we're getting the young adult males to renew their membership because of the technology. And they are a group that will not use the health services very much. So what are the lessons to share with our African cousins? Ghana's health insurance has bipartisan political commitment. All sides of the House support the health insurance scheme. We have an innovative financing model. It is completely domestically resourced, and we can all find ways of finding that little bit of fiscal space to invest in health. We have an extensive pro-poor exemption policy, probably a little too extensive, but it means that we will leave no one behind, hopefully. We have a decentralized approach to implementation. We have regional and district offices where a lot of what is going on happens. The health insurance has meant that the government or the health sector has invested in training of the middle level of health cadres because of the mushrooming of health facilities around the country. We don't need so many more specialists, but we definitely need that middle cadre to take care of primary health care. Location of facilities in deprived areas, we find the private sector are actually moving out of the cities into rural areas because, as I say, the market is there. The health sector is finding innovative ways to retain health personnel. The brain drain is not happening as much now that we have a vibrant health sector. Equity in distribution of the infrastructure, and although it was very rough at the beginning where meetings around the scheme resembled boxing matches, today we have very good and effective stakeholder dialogue between all parties trying to achieve UHC. So these are some of the lessons for us all. So in conclusion, we are extremely proud of our health insurance despite the challenges, and we believe that UHC is achievable for all within the African subcontinent. We just have to adapt to fit our country context. Thank you very much.
Thank you very much, Dr. Selby. I now have the privilege to invite Professor Kwan to deliver his presentation.
Well, it's my great honor to participate this AfHEA meeting and also have a chance to present this in this session. The purpose of my presentation is, to discuss the policy lessons from the Korean NHI for UHC, both successes and failures. And also, I'd like to take this opportunity to examine some key issues related with UHC with a lens from the Korean experience. First, let me briefly mention what are the systems, what are the achievements of this system before I'll talk about the challenges and some failures in the system. First, Korea has been quite successful in the rapidly expanding population coverage. We first introduced insurance for the formal sector workers in large firms and incrementally extended it into small businesses and informal sector in rural areas and urban areas. So we achieved the kind of universal coverage of population in 1989. Then what are the contributing factors to this very rapid extension of population coverage? There is a very strong government commitment and political will for the mandatory enrollments, because at that time we had a political authoritarian regime, and this political authoritarian regime in a sense had a very strong will, political will for the legitimization of the regime. And also we had a very rapid economic growth, which made it quite possible in the expansion of the welfare state, whereas in some of these East Asian countries, it's not really a bottom-up approach, but rather the authoritarian political regime played a very important role in the top-down policy and introducing and expanding the welfare schemes, including healthcare financings and health insurance. Another factor is Korea adopted the family-based membership. It's not just Korea, but like Philippines, for example, had a family-based, it's basically dependence coverage. So you can see the family-based membership or dependence coverage contribute to the rapid expansion of the population coverage, because when the family head is enrolled, the other dependents are automatically enrolled. And also in some countries like in Vietnam or other part of East Asian countries, because before achieving a universal coverage of population, there is a different small schemes covering different segment of the population, like a children's scheme or elderly scheme. Sometimes it contributes to the fragmentation of the overall pooling. So I think that in that sense, dependence coverage is an effective way to overcome some of this fragmentation. And also, if you have the global experience, you can see that a unique ID system and a very good civil registration and vital statistics system can help this type of dependence coverage. In terms of contribution setting, like other countries, Korea had for formal sector workers, the contribution is proportional to income. So basically, it's an earmarked proportional income tax for the formal sector, and it's equally shared by the employer and employee. But as you know, that the contribution setting for the self-employed employee is very tough. It's a main challenge. So Korea, similar to Japan as well, we adopted a contribution setting based both on income and property of the self-employed. And also, we started to provide like a half of the contribution of the self-employed from a government subsidy part. Okay? And then incrementally, government subsidy component or proportion is declined. But these days, government subsidy is much smaller than 50%, but we started with a 50% subsidy for the self-employed. But as you know, I mean, without government commitment in financing, without government subsidy, if you rely only on contribution scheme, as far as I know, it's almost impossible to achieve the UHC. So the role of the government subsidy or financial commitment is a very important factor. In terms of pooling, we started with a multiple pools, very similar to Germany and Japan. So we started with the multiple pools, like more than 300 pools, and then we merged all of them into one in the year 2000. But even before this merger of 2000, Korean system has a kind of pooled purchasing mechanism because it had a uniform statutory benefit packages across schemes and uniform payment for providers. And around the time before the merger, the claim review and assessment is centralized. So these all factors contributed to rather successful merging of all insurance schemes into one. So in general, we know that the single pool is more efficient and equitable than multiple or fragmented pool. But again, there are a lot of contextual factors. In the case of Asia, like Vietnam and Indonesia is a nationwide single pool. But if you do not have an equity or equitable distribution of healthcare utilization across different regions, especially rural and urban, single pool does not necessarily achieve a total equity. So this single pooling in financing should be accompanied by equitable distribution of delivery system. Then it can contribute truly to the efficiency and equity of the pool. In terms of governance of an insurance system or strategic purchasing, Korea has a relatively good purchasing mechanism based on ICT, but still there is a major breakthrough of this purchasing mechanism happened after the merger of all insurance societies in the year 2000. But another very unique characteristics of the Korean system is that it's a single pool, but there are two agencies working in this health insurance system, and they are divided in terms of functions. So we have a big agency called National Health Insurance Service, deals with premium contribution, fund management, reimbursement. And also it's a bit interesting that this agency collects not only the health insurance contributions, but all insurance contributions are centralized by this agency. In other words, pension, workers' compensation, unemployment insurance, health insurance, and long-term care insurance. All premiums are collected by this agency and then distributed to different social insurance schemes. And we have another agency called Health Insurance Review and Assessment. It deals with claim review, assessment, and payment system designs. So this type of division into two agencies is quite unique. I haven't seen any global experience in this kind of thing. So risk pooling is a single, but governance system is a bit divided in terms of functions. So some positive side is that, well, if you have one big single insurance agency, we might be worried about potential bureaucratic failure and lack of responsiveness. For example, NHIS is a big agency. It employs more than 10,000 workers, staff there. So in a sense, another agency can be a potential competition. So it's from an economic theory of principal agent, it can be a double agent model. So Ministry of Health sometimes can compare the performances, but also it has some problems, potentially coordination failure. So it's pros and cons. In terms of policy making, we have a health insurance policy committee. So all major decisions on premium contributions, pricing of services, and benefit packages, that decisions are made by this committee. It's kind of a tripartite committee. So 8 members from payers, 8 members from providers, 8 members from the public body, like the Ministry of Finance, Ministry of Health, Insurance Agency, and 4 independent experts. And also, the role of the Ministry of Health and Welfare is very strong. Remember that in Korea, the majority of providers, more than 90% of the hospitals are private. So Ministry of Health and Welfare has never been a service provider. So that's, in a sense, that's why Ministry of Health and Welfare is deeply involved in the policy formulation of healthcare financing, and 2 insurance agencies, NHIS and HERA, are kind of implementation agency. And Ministry of Health and Welfare is deeply involved. So, but I see that from my own experience of providing policy advice to many low-income countries, I see the relation between ministries and this insurance agency is very delicate. Sometimes we propose there should be a separation of purchasing and provision. But, so in a sense, if the Ministry of Health service provider and purchasing agency, they are too close, there might be a potential conflict of interest. But if they are too distant, we had coordination problems. So I do say there's an optimum distance, between this Ministry of Health and purchasing agency. And even further, some countries like Mongolia, Cambodia, Laos, even China, it's not just the Ministry of Health, but Ministry of Labor or Social Welfare are deeply involved in health insurance policy. So sometimes there are conflicts between different ministries over the governance of healthcare financing system. So this is a paper I wrote about Korean system about 10 years ago. That is about 30 years of introduction of NHI in Korea. This is another paper I published last year. It's a very more updated version of the Korean system published by World Bank. And this is about overall East Asian or WHO, Western Pacific Regional Office's country perspective on financing. Evolutions. So Korea started with, policy priority was given to the population coverage. There's some sacrifice of the benefit packages. So we started with the really minimum benefit packages. And then we had some issues of financial protections. So we introduced a further protection mechanisms like discounted copayment for elderly and children, a reduced copayment system for catastrophic diseases, or we also introduced a ceiling on the cumulative out-of-pocket system, but still, it does not solve the problems because these mechanisms applies only to the services in the benefit packages. And private providers, they are very clever, aggressively introduce and induce demand for those services not in the benefit package and new technology, new services, because those new technology, new services are not subject to price regulation. So this example of Korea shows the clear relation between provider behavior and financial protection. Financial protection is not simply a financial matter. It's closely related with the provider behavior. So, as I said, out-of-pocket payment official or co-payment for health insurance only 20%, but out-of-pocket payment in overall healthcare expenditure accounts for more than 35%. Because provide cost effectiveness. As an economist, I fully support the importance of cost effectiveness or economic evaluation for the benefit package decisions, but that is not enough because these benefit package decisions is inherently a value judgment, priority setting. So these days, Korea is experimenting with a citizen participation models. So in a sense, expert community provide evidences of economic evaluations, but based on the multiple various options, we also incorporate the citizens' participation and value judgment, social value judgment, to have a final decisions on the benefit packages. So this is a good example that we need a fairness, not only the final outcomes, but also we need a fairness in procedures or so-called procedural justice. So we need both evidence and values. Evidence is provided by expert, but we need a value judgment of lay citizens. Another issue is that contribution. What is insurance? Does insurance mean that health insurance premium contribution? We started with that type of concept, but over the years, we expand this contribution base toward a bigger and bigger. Okay? Especially for the self-employed, we set the premium contribution based both on income and asset, but conceptually, it's very difficult because how to combine income, which is a flow, and asset, which is a stock. Okay? So we are moving away from the contribution setting based on stock, asset, and moving toward an income. In other words, we want to charge contribution based on all types of income. Not only on payroll, but also interest incomes, income from the rent. Because that's the idea of payment based on the capacity to pay. Okay? So that's the direction. So currently, we also charge a contribution on the non-wage income over a certain threshold. But we are trying to reduce the threshold. And eventually, there should be no threshold, such that we charge insurance contribution on all types of income. That is more efficient and equitable. And then NHI contribution is really will be viewed as an earmarked proportional income tax. Challenges. First, financial sustainability. As I just mentioned, healthcare financing based only on wage or payroll in the formal labor market is not sustainable. Especially in Korea, we are facing a rapid aging of population. So, people live longer and longer post-retirement life. So if you charge contribution only based on payroll tax in the labor market, this system is not sustainable. And also another important element for the financial sustainability is the payment system reform. Still, Korea's predominant form of payment system is a fee for service. We all know the inefficiencies of fee for service system. So we need to, Korea, we need to expand the role of the case-based payment and go further to the bundled payment to cover all different types of care, from primary, secondary, tertiary care, more toward the population-based payment. So this is, you can see that this is the average annual increase in healthcare expenditure for the last 10 years among OECD countries. We are experiencing a very rapid increase in healthcare expenditure only after Chile among OECD countries. More striking figure is the number of physician visits per capita. It's the number one in the world, more than about 16 times a visit. What do you think? Is it a good access or demand inducement? Judgment is yours. Another issue is the aging of population. In terms of the speed of aging, Korea is number one, unfortunately. There's a very rapid increase in life expectancy and rapid decline in fertility. So we introduced a long-term care insurance, separate from health insurance. Again, following the example of Germany and Japan. So it covers about 7, 8, 9% of the population over 65. But still, there are a lot of issues. We're just celebrating the 10th anniversary of this 5th social security, social insurance program in Korea. There's a balance between institutional care, home-based care, community-based care, because we all know aging in place is very important. And also the issue of the coordination between health insurance, long-term care insurance, because there are a lot of gray areas between these two different insurances. So there's huge challenges for us. Issues of population aging, and especially this long-term care insurance and coordination between health insurance and long-term care insurance, how to overcome the discontinuity among these two and overcome the fragmentation among different service providers. This is speed of aging, highest in the world. Thank you.
Good evening, everybody. I'm the country representative of Kofi Ghana office. We have heard about the two countries' national health insurance systems. As each country's strengths and challenges are very unique, we have good reasons to collaborate to improve each country's system. Now, Mr. Ando, Director of RPME at National Health Insurance Authority of the Republic of Ghana, will introduce our collaborative efforts to achieve UHC in both countries and further act as global hubs for UHC. Mr. Ando has been managing our cooperation project since the inception in 2013 up till now. Please welcome Mr. Ando.
Yeah, thank you, Jane. So I'm here this evening to present the NHIA Coffee Collaboration Project, which started somewhere in 2013. So this will be the table of contents, background activities, pilot projects, achievements, and then the way forward. As background, I want to say that this initiative came from the Ministry of Health. The Minister of Health at the time, around 2012, had discussion with the Korean delegation, and one of the key issues that came out for discussion was the need to support Ghana's health insurance in the area of expanding enrollment. So, National Health Insurance Scheme and the National Health Insurance Authority were recommended to the Korean Foundation for International Healthcare, that we cut short COFI. So, official request letter from the Minister of Health went to COFI in 2012. And from there, policy consultation and dialogue between NHI and COFI continued from 2012 through 2013 to date. Now, some of the key issues that arose from the dialogue were: one, at the time, NHIS had reached about 10 years, but yet enrollment was still a key issue. So there was the need to support Ghana to move towards the attainment of UHC. But through the discussion, one thing came up, that areas of support should be evidence-based, that Koreans will want to make sure that whatever issue that comes up for within the cooperation agreement should come out of research, so that they will be sure that these are the issues that we really need. So there was a research into the barriers of enrollment, because that was the issue that was put on the table. And baseline study was therefore conducted, first qualitative study in 2014, and then followed by a quantitative study in 2015. Out of these studies, interventions came up for implementation. Now, key findings of the baseline include: one, personal factors. Affordability of the premium was an issue during the pilot study. Others were scheme factors. And one key issue was that the distance between the residence of the potential members and the office location where they have to register was too far. And that discouraged them from enrolling onto the scheme. And there was also knowledge gap. It came out from the study that most of the respondents didn't know much about the benefit package, what it takes for them to get registered, and what is in there for them. So for them, the need wasn't there. But others also mentioned health service factors, which is access to healthcare facilities. The area that was captured for the pilot, in most places, they found it difficult to get healthcare services. So for them, if they have to be on health insurance and they cannot get the service that they need, then there was no need for health insurance. So out of these, we came out with 3 interventions. One was registration expansion through outreach program. That was to take care of the distance issue between where they reside and where they have to register with the insurance. And then the issue of affordability, we came out with financial incentive to encourage group registration based on the family unit. And then the next was information, education, and communication to explain, take the enrollment arrangements close to the people so that they can register onto the scheme. So it took the form of outreach registration with mobile kits, and then the idea of premium discount on group registration, and then also basic medical screening at the CHIPS compound. And that was introduced into the program to entice the people to come and register. So whilst you avail yourself for the registration, you took time off to go through basic screening. Then the IEC took place in Ketu North District, which is still in the present Volta region. Now it took the form of radio broadcasts. They used information vans to go around the district to inform people about the scheme. And there's school promotion. We organize quiz in the schools all about health insurance for the people to learn health insurance right from the school. And then posters and leaflets in health facilities pasted all around. And then the NHI staff in those districts were also given training in how to engage the people and communicate effectively to them. Now, at the end of the first pilot project, this is the impact that the intervention had. We had 3 districts. 2 were the intervention districts, that's KJB and Ketunov. And then we had another district far away from these 2 districts to serve as control, so that we could measure the impact against this district to see how effective it was. And for the communication one, compared to the control district, the intervention had 5% impact. And that was 5% increase in the active population, active membership against their population. Then when it gets to the KJB side, where they actively took the registration centers to the people, and then also enticed them with some basic screening, that had 7% impact. Now, based on the success story of the first intervention, we made a case that 9 to 10 months of implementation wasn't enough to have a big impact of the intervention. So there was a need for them to extend it for another year. After a series of discussion, this was agreed. And so a second pilot, or continuation of the first, started. And this one was from April 2018 to December 2018, the same year. It was 9 months. And we had learned from the first pilot that the idea of incentivizing the people with reduced premium for the group was not in tandem with internal policies. So that could not work on the ground there. And then we also found out that, yes, the communication had some impact, all right. But then, if you go out to get the people registered, you cannot separate education from the registration. So we saw the two to be the 2 sides of the same coin. And so we made a case that why don't we combine these 2 interventions and put it in one place and see how effective that will be. And so all these things were concentrated in KJB that was already doing the active outreach registration. So we created 13 registration points to serve 98 communities in the district. This was made to make sure that at least everybody within the district, or every community in the district, will have equal chance of getting registered onto the scheme. So I've explained this one. So at the end of the second phase, this is what we came up with. So now it's KJB against 2 control regions, districts. But one of these districts, we can say, has been a bit contaminated because they had an intervention that was communication. But that notwithstanding, we went ahead. And for that particular district, comparing it with KJB, the impact was 4.8%. And then for KJB and the real control district, it was 7.5%. And we see this to be a bit closer to each other. And we are contemplating, is it not because probably the education had a long-term effect and that the spillover effect was able to get more people register in Ketu North, even though we did not put the second intervention there. Now, those two interventions were not the only aspects of the collaboration that we had with our partners. So other aspects of the collaboration included staff capacity building through invitational training. And through this, about 95 people within the scheme, the NHIA, benefited over a period between 2013 and 2018. They were invited to Korea to go through training in health insurance management. Then we had also technical support through on-site training. This is where experts from Korea came to Ghana to be with our staff, especially those in claims and ICT department, to help them to improve their workings and how to make their system work better for Ghana. Then there was also sponsorship to international UHC fora in Korea. And as they say, 2 heads are better than 1. So at least 2 people at a time over the period were invited to Korea to attend the International UHC Forum. Then beside that, we also had logistical support. We benefited 1 4x4 to support M&E activities, and that is located at the head office. 1 double cabin pickup truck to support district-level activities, and this was purchased during the second pilot phase. So it was given to KJB that was doing the outreach program. And then we also bought 4 motorbikes from this collaboration. 2 were given to KJB and 2 were given to Ketu North. In fact, they were originally scheduled to be purchased during the first pilot, but procurement process delayed the process so that we couldn't buy it at that time. So even though Ketu North was out of the actual implementation of the intervention, we still gave them 2 of the motorbikes. Now this is a summary of the activities that I've talked about, a whole lot of them. And I don't think I need to go through again, otherwise it will be a repetition. Now, what are the responsibilities and roles of the partners? For coffee, they were involved in strategy development, monitoring and supervision, and then providing budget support. And this was done by the Ghana office in Accra, and then the Korea office in Korea. For Ghana, our role was to implement the project, and for NHIA, at the head office, to disburse the funds to the districts as we get them from Korea. And then also monitoring and supervision. And we make sure that we also do fund audit to ensure the funds are being utilized the way that had been budgeted for. And then, of course, reporting to our partners, both operational and financial issues. The NHIS and HERA in Korea were also involved in the monitoring. So in all the 2 projects, the 2 pilot phases, Ghana was doing monthly routine monitoring and supervision, but midway, our counterparts from Korea joined us to do joint monitoring. And this is just to make sure that there is true accountability. And they also provide technical support for the implementation and then training of the Ghana NHIA staff. Now, the other partners are our regional office in Ho, and then the districts that were implementing the project. So the role of the regional office was routine monitoring and supervision, technical support to the districts, and budget receipt from the head office. Then for the districts, achievement was a joint research that was published in a peer-reviewed journal, and that was led by Professor Irene Ejepon. He was the principal investigator for the first project, and they came out with a very beautiful article that was published in the peer review journal. I've also talked about the registration expansion that achieved an average of 7% impact. Now, so what is the way forward? The way forward, so far, the direction of the discussion is that our partners in Korea are willing to continue with the project in the second phase. And for the year 2019, we are using it for planning. And then from 2020 through to 2023, 4-year period, we'll be implementing the next project. And the focus will be to support Ghana and position it as a pivotal country for achieving universal health coverage in Africa. We're telling our Korean partners that we see you as the giants in Asia when it comes to health insurance because you achieved your UAC in a relatively short time, 12 years. And so Ghana too has been about the first in Africa to have moved towards universal coverage by including both the formal sector and the informal sector onto the scheme. But we also have challenges. We haven't reached there yet. Can you also help us to also be the African giant in health insurance? So that is where the project is going. And it's scheduled for 2020, 2023, as I said. And all other things being equal, and if the budget doesn't change, we expect no less than $2 million to implement the next phase of the project. Now, the project will involve 3 key areas: research, training, and then the establishment of a health insurance knowledge sharing center. We initially mentioned that it's a center, but then we also thought that in order not to duplicate things and invest money into infrastructure, why don't we identify some of these centers or training centers in the existing universities and work with them? So we identify CHESPO, Center for Health Systems Policy and Research at GIMPA. And since it is already a center, the discussion is now going this way, that instead of calling it Health Insurance Knowledge Sharing Center, we're going to call it Health Insurance Knowledge Sharing Program within the CHESPO, at least for the time period that this project will be implemented. So this one was given as a last slide to give a summary of the roadmap. You have the official request letter, comprehensive MOU between Ministry of Health and Kofi, and that's why I said the initiative was from the Ministry of Health. Had a first pilot project, and then the second one, policy dialogue, joint research, baseline study, second pilot, baseline published, policy consulting, joint research, baseline study, pilot project. Now we are at the policy application stage. And once our final report is approved by all the stakeholders, we'll also start dissemination by publishing some of them in peer review journals. On that note, I would like to thank you all for your rapt attention.
Good evening. Thanks for joining us all. My name is Benoît Mathivet. I'm a senior health economist at the World Bank. And as a last move for this session, what we would like is to tease your brain and to stimulate you for your comments and questions. So we'll have a comments session. And for this, I'm very pleased to invite Adam Wagstaff. Adam is the research manager of the Human Development and Public Services team as part of the Development Research Group at the World Bank. He's been at the bank for 20 years, and before that, he was a health economics professor. And he's been the president of the International Health Economic Association from 2016 to 17, if I'm not wrong. And everyone knows Adam's work on health financing policy, on equity of access, and on applied method to tracking progress toward UHC. So without further ado, I'd like to ask you, Adam, to join us. Thank you.
So I realize that I stand between you and a good discussion and cocktails, so I'm going to try to be brief. I'm going to focus less on Ghana and more on Korea and the lessons for the developing world, because I'm afraid I didn't get the presentation about Ghana until, well, I didn't get it actually. So I only heard it when you heard it. And I'd like just to start by standing back a little bit and asking what it is we're trying to do when we talk about growing health insurance schemes in the context of trying to achieve universal health coverage. So I'd just like to make a plea that we don't equate getting people into a financial protection scheme with achieving universal health coverage. Universal health coverage, to me at least, and I think actually to most of us, because this is now enshrined in the SDGs, is actually about two things. It's about ensuring that everybody, rich and poor alike, gets the health care that they need, and that their families and they do not suffer undue financial hardship as a result. So part of UHC is about ensuring service coverage, if you like, and part of it is about ensuring financial protection. No country in the world has attained UHC in this definition. And there are many countries around the world that have 100% of their population in a financial protection scheme and are a long way from attaining UHC on this definition. And many countries, particularly countries in Latin America, that have constitutional guarantees to health and health services that are also a long way from attaining UHC on this definition. So I know it's tempting to equate achieving UHC with getting everybody in a financial protection scheme, but I would love it if we could leave Accra and realize that that is not actually the way we should be thinking. And I was encouraged by the Ghana presentation, actually, where the presenter said that actually the goal of the health insurance scheme is financial protection, meaning it's not about just getting people into the scheme, it's ensuring that the scheme actually works and improves and attains financial protection. So there are these two aspects to UHC, service coverage and financial protection, and I thought it would be interesting just to reflect a little bit on Professor Kwon's presentation and ask, how does Korea fare, and what lessons are there for developing countries from Korea's experience? I should preface my remarks by saying it could be that, as in India, people have a lot of repeat visits because they never quite get their health problem fixed the first time, and the doctor's got an incentive to get you back, and next time I'll really fix you. Or it could be that, rather like the child who's immunized several times, their needs are being addressed multiple times, and they didn't need to go back for their second, third, and fourth visit. They could have been fine just not coming back at all. I think it's better to look at indicators where needs are well established or easy to identify, and meeting them is much more clear-cut. So if one looks, for example, at cancer screening in Korea compared to other OECD countries, we see that Korea doesn't do that badly, in fact. If you look at mammography and pap smears, Korea is in around the 26th percentile of the OECD countries. That's higher than the percentile Korea is in on the financial protection indicators. So basically what comes out of this, I think, is that on financial protection, Korea performs less well on service coverage, and is probably in financial protection in the bottom quintile, if not the bottom decile of the OECD countries. On service coverage, at least on the basis of these cancer screening indicators, Korea is probably about the top of the bottom quartile. So what then are the lessons for developing countries from Korea, and perhaps Ghana in particular? I think one key lesson here is that Korea 30 years ago this year, is that right, Professor Kwon? Or last year? 40 years ago, yes. No, the achievement of universal enrollment. Yes. So 30 years ago, according to the definition of getting everybody into a scheme, Korea achieved this universal enrollment, universal coverage. But what it illustrates rather nicely is that that wasn't sufficient to achieve financial protection. And actually, some OECD countries which didn't go down the social health insurance route have got superior coverage, as of course have many social health insurance countries. So this emphasis on getting people into a social health insurance scheme is a challenge, I think. This career experience, I think, gives us pause for thought. In the case of Ghana, what we're seeing is a concern about enrollment being less than 100% and declining. The app is seen as a way to facilitate renewal. We've got some interesting pilots to increase enrollment in the career collaboration. The results of those two pilots I found rather interesting, actually, because I did a couple of experiments, RCTs, in the Philippines and Vietnam, where we used a mix of information and subsidies, and we had no effect whatsoever. So I congratulate you for these wonderful size effects you achieved. What we did find in the Philippines was that when we did a lot of hand-holding, actually undertaking to go and do the enrollment on behalf of the enrollee, we did start to get an effect. But that made me think, well, what are the costs of the activities aimed at increasing enrollment and re-enrollment? We were hearing about 4x4 vehicles and lots of things, and I'm wondering what on the cost side these activities are. And it does raise the question of, if you have to go to so much expense to bring people into a scheme, isn't it better perhaps just to use tax revenues? I was also wondering whether the inducements that you were thinking about or you had piloted would be as effective on the question of re-enrollment. So, for example, medical examinations are valuable this year, but are they equally valuable next year and the year after? It's not everybody who needs a health examination every year. So what are some of the other lessons? It seems to me, looking at these statistics on financial protection and service coverage in Korea, it's important to understand what it is that's driving that performance. So, as Professor Kwon pointed out, the benefit package is very narrow in Korea. So looking at the new WHO data, it turns out that only 44% of total health expenditure is spent by Korea's social health insurance scheme. The figure in Japan is 70%. In Germany, the figure is 75%. So that's a reflection of the narrow package, that so little of total health expenditure is being driven by the agency in a system that is, notionally at least, a social health insurance system. As Professor Kwon reminds us, these services that are not covered by social health insurance are paid for out of pocket, and the prices are not regulated. They're delivered by private providers who compete with one another, and Professor Kwon's hypothesis is that they compete with one another and try to take advantage of the informational asymmetry between patient and provider to induce demand, to shift demand, in fact, from covered to uncovered services. And that's what's driving part of this financial protection problem. So this raises, I think, an interesting question for the design of social health insurance systems at the start. So the question, it seems to me, is, does starting with a narrow benefit package and leaving the private sector, an unregulated private sector, to cater to uncovered services, make it hard for a social health insurance scheme ever to achieve a comprehensive package? Is there just always going to be too much resistance from a private sector that's unregulated, that you're saying, guys, it's coming to an end, pack up shop, because we're taking over these services? I think that's really a big challenge. In Ghana, I was interested to hear that actually The covered services are in fact the more costly ones, and the concerns are about under-incentivizing the uncovered services, which are primary care. So that was an interesting take. I wonder, though, whether there's more to it than that, and I'm not a Ghana expert. I didn't hear much about pharmaceutical expenditures in actually any of the presentations, which I was a little surprised by, because Korea adopted a reform in the year 2000 to separate prescribing and dispensing of medicines, which up until then had been seen as a cause of Korea's high pharmaceutical expenditures. I was struck when I looked at the new OECD numbers that even now, nearly 20 years after that reform, Korea still has a high, by OECD standards, pharmaceutical expenditure as a share of total health expenditure. It's 22.5%. It's down from what it used to be, but it's still high compared to the OECD average of 14.5%. So I'm wondering, do we understand enough about the other system features that explain Korea's high pharmaceutical expenditures, and what lessons are there for developing countries? I was also interested to see in the Korea-Ghana collaboration, there was work on drug registration and management, and I wondered what the lessons that were coming from Korea were that were being incorporated into that collaboration. Lastly, and very quickly, I'm struck by the fact that there are many mechanisms in Korea's health system to protect the poor and otherwise unlucky, people who acquire expensive medical conditions. There are protections both on contributions, but also on out-of-pocket expenditures. And it's quite possible these have an impact. But the data suggests, the aggregate data, when we're comparing Korea to other OECD countries, the data suggests that they're probably not sufficient. And I think Professor Kwon is probably absolutely right to suggest that part of the problem there is that these measures bite only on the covered services, not on the uncovered services. Are there other lessons from Korea, and what are the lessons for Ghana on these issues? I see that in Ghana, 2/3 of members don't contribute. Apparently, those are the poorer ones. The Ghana presentation suggested that that was perhaps too generous. We perhaps might be thinking about having less than 2/3 being exempt. But then the question arises, is it realistic to persuade those who are currently exempt to actually start contributing?
Thank you very much. The 20 million cedis I talked about is the estimated saving to members who want to renew in transport costs. But savings to the NHIS, we estimate that it's in excess of 100 million Ghana cedis annually. Savings in consumables associated with renewing, because we used to print on the back of the cards, and that is actually quite expensive. So once we do away with that part, we think we're going to save 100 million Ghana cedis. To set this up, we did a lot of the applications in-house. So the only cost actually is the SMS messaging. USSD technology costs us nothing. So the star 929, I think we pay 1,000 cedis a year to use that short code. It's the SMS messages to the members and to the provider that costs us. But it is peanuts compared to what we were spending before. The whole project was done with a facility through the ILO, the French Development Agency, $50,000, and I still have a lot of it left. Can we afford 100% coverage? We are extremely adversely selected. The difficulties with renewal means that it's those who need to use the card who are on there. And we need to target the healthy and the wealthy to reach our 100%. So I'm not saying that we won't get some increase in claims expenditure, but I don't think it will be a direct exponential increase. Everybody who has a card has it because they need to use it. So the diabetics, the hypertensives, they all have health insurance and they queue long hours to make sure they renew because they need it. So, I mean, obviously it will be interesting to see what happens going forward. But I really don't think it's an exponential increase. And secondly, everybody has been talking about investing in health. We will find the money if we think it's important enough. So I'm not that desperately worried about us achieving 100% coverage. Thank you very much for the interest shown in Ghana's system. I'll start from the questions from Senegal. Dialysis, chronic dialysis is not covered at this time. We do cover acute dialysis for acute renal failure. So it's just a couple of dialysis sessions. Talking about mandatory enrollment, Ghana has a lot of laws. It doesn't mean the citizens are obeying the laws. It is very difficult to punish somebody you are trying to help. The health insurance law is a social protection law to help a citizen. If that citizen is refusing your help, it is difficult to punish the person. What we are looking for is innovative ways to make enrollment mandatory. So for instance, currently, if you want to attend a boarding school in Ghana, you must have a national health insurance card or the school will not accept you. It's these kind of ways that are increasing the enrollment for certain groups. We need to find a way to tie having a health insurance card with something that Ghanaians want very badly. And once you do that, enrollment will shoot up. We have some ideas in mind, but we needed to ensure that our district offices were free to accept all the people who want to come. With this mobile renewal technology, our district offices are decongested. So we can begin to tie or persuade the government to tie ownership of the NHIS card to certain things Ghanaians want. If tomorrow you told Ghanaians they couldn't get on an aeroplane without a health insurance card, they cannot apply for a visa to US, UK, Schengen and all that without a health insurance card, we'd be overwhelmed. So it's about finding ways to tie enrollment to something that the citizens really want. How do we handle issues around quality of care? We have credentialing. We do inspections. The hospitals are graded, and the grade is on your certificate. So everybody knows where you fall. If you fall below a certain standard, we can take your credentials from you and you cannot see health insurance members. Obviously, it's a challenge when it's a government facility, and we dialogue with Ghana Health Service to improve whatever standards we're looking for. If you are the lone provider in an area, to shut down the facility doesn't make sense. So it's about using the structures in place to improve the standards within the facilities. And then I was asked about how to finance NHIS without resources. You'd be surprised how you can find resources if you really want to. I think in this morning's plenary, Dr. Asamoah talked about how if it comes to war, we can all find ammunition, finance our armies and things, but somehow we can't find that money if we want to invest in health. There are ways and means. When Ghana was starting its health insurance, it was about going to the people and saying, haven't you had enough of cash and carry? Haven't you had enough of going to a hospital and being asked to put money down before you are even looked at? The numbers of avoidable deaths, especially in children, really spurred the Ghanaian public to understand that if we all contribute a little, we can make it. And therefore, when the levy was introduced, it was introduced without a whimper. And that is what is sustaining our health insurance scheme. There are other African countries who are introducing talk tax on the use of mobile phones and diverting some of that to healthcare. I think we can all find ways, but it must be within your country's context. To find that little bit of room to fund your healthcare, whether it's through health insurance or resourcing the Ministry of Health directly, whatever. But I'm sure we can all find a way, as long as you account for the money properly. Our citizens don't mind paying. We didn't talk about hierarchy in healthcare because we only had a short time. 15, 20 minutes is not long enough to give all the details of the health system. But we do have a hierarchy, primary healthcare to secondary to tertiary. And in fact, if you skip and get to tertiary, and the tertiary facility wants to care for you, we will pay primary care tariffs to discourage the diarrheas and malarias and upper respiratory tract infections ending up at the tertiary hospital. It doesn't always work, but it's something we are working on quite hard. And then the introduction of new things into our health insurance scheme. We have a benefit package, we have the treatments, we have agreed tariffs. We don't introduce new medicines, new procedures lightly. It goes through an expert committee and discussions supervised by the ministry before new things are added to our benefit package, because we must always be mindful of cost as well. Thank you.
Thank you. I think you're right that most sub-Saharan African countries, the case that MOH is the service provider, but it's not just Africa, it's the case for the majority of low and middle income countries of Asia. Korea case a bit unique, similar to in Taiwan and Japan, but Korea is a bit too much. The majority of the providers are private, so that's why that is a unique situation that Ministry of Health is not a really service provider, and they are more like the kind of policymaker. So that means that if you visit the Ministry of Health, the majority of the government officers in the Ministry of Health are not clinicians. So that's the case. But we do have a public health centers in all local government, although its role is very controversial. I think that the interesting question can be, what is the impact of the kind of insurance mechanism or social health insurance mechanism on the public sector provider or primary care? I mean, from my own experience, over the last 20 or so years working in Korea healthcare system and other systems around the world, I think, unfortunately, that some people say social health insurance has a benefits or advantage of giving people the choice between public and private providers. But in reality, it seems, if you look at examine the trajectory of development, in many countries, once the social health insurance is introduced, government tend to neglect its important role in the service provision. And then people increasingly demand care from the private providers, and I briefly mentioned this in another session, but some kind of passive privatization such that it's not really government privatized public hospitals, but all the increased demand for healthcare is met by the increased supply of private providers. Is it good or bad? Unfortunately, I've observed many negative impacts on this increasing dominance of private providers in the market. Another impact is the primary health care. Again, I've seen that in many countries in Asia, after social health insurance is introduced, people increasingly bypass public primary care. Like recently I was consulting to Vietnam, so now they realize that, wow, public primary care is almost in the coma situation. Then, as you know, once the primary care is neglected, the public sector, there are a whole lot of problems. So we should really think about the question of what is the impact of this new financing mechanism on the primary care or on the public care deliveries. I mean, it's a choice is yours, but we need to do our best to minimize potential negative impacts of this. And as Adam mentioned, I think the financial protection is the Achilles heel, and also mentioned in my presentation. Financial protection is the Achilles heel of Korean healthcare system. And as I said, it's not really financing issue. I think it's more deeply rooted in the service delivery part, again, in the private sector domination. Government put a lot of money in the past so far to expand the benefit packages. But the thing is, private providers, 90% of the hospitals are private, they more rapidly introduce new services, which is not yet included in the benefit packages. So how to control and monitor these private providers is a big issue. It's not just a financing issue, again, it's from a political economy perspective. Now these private providers is a huge, key stakeholders, vested interest groups. Luckily, Korea now, we have a very progressive government. But again, without controlling the prescribing behavior of providers, we can rarely succeed in controlling the whole pharmaceutical expenditure.
I think we're done with the question and with this session. So I would like to thank our presenter and to thank you all and to invite you to a cocktail.
Thank you very much. It's been a very long day, full of technical talk and technical discussion. But indeed, that is what the essence of the program is. So I hope you've had some useful pointers to help us fashion our own systems better. So we are essentially done for today. Tomorrow starts just like today at 8:30 a.m. And then the World Bank is hosting a cocktail outside, so feel free to join. Yes, feel free to join, have conversation, have a drink.